So let's go ahead and get started today. My name is Becky Sanders. I am the Program Director for the Upper Midwest Telehealth Resource Center. I want to thank you for joining us today. Today we'll be talking about Ohio Medicaid and maternal health. And we have with us today Nicole Small, who is the systems administrator. Sorry, Nicole. You're my Medicaid person. You're my go-to. Who is a health systems administrator for the Ohio Medicaid department. We've got you all in listen only mode today, and we are recording this session, and we will make that recording available via our YouTube page, as well as posted on our archive webinars of our website. And we will send out the slides after today's presentation. So let's go ahead. Oh, I do wanted to mention, please use the Q&A function at the bottom of your screen if you have questions. Carolyn Miller is with us today, and she will be answering technical questions behind the scenes. So you have a technical question, go ahead and use the chat to chat with Carolyn. And if you have a question for Nicole or I, please use the Q&A function. We probably will wait until the end of the presentation to answer questions, but Carolyn will kind of check that out as well. If there's something that we need to take a pause in the presentation and address immediately, then we can do that. All right, so I'm going to go ahead and share my screen. And just full transparency, I have two screens. So I've got my camera here on this screen and I've got my slides over here. So if I'm looking to my right, then that's because I'm referencing the slides. All right, so we can't start a Telehealth Resource Center webinar without talking about the National Consortium of Telehealth Resource Centers. So we here at the UMTRC, or the Upper Midwest Telehealth Resource Center, cover 4 states. We cover Illinois, Indiana, Michigan, and Ohio, the lilac states on the slide. There are telehealth resource centers that cover all states in the United States. The federal program where our funding comes from is through HRSA, through the Federal Office of Rural Health Policy and the Office for Advancement of Telehealth. At the federal level, the program's been around since 2006. And we do now have 2 national centers as well as the regional centers, one for policy and one for technology. And so together we all form the National Consortium of Telehealth Resource Centers. And we've recently redone our map, or our website, as well as our map with updated logos. And so you can go to the national website at telehealthresourcecenter.org and reach out to any of the 14 of us. We also have a monthly webinar series and events, calendar events throughout the nation of all of the things that the telehealth resource centers are doing. Here, our focus in our 4 states, we consider ourselves virtual librarians. And especially during COVID, so many of the things that we do are virtual. We might get what we call technical assistance requests, or TA, come to us either through the website, on our website, or through the national website that get directed to us. We might get emails directly from individuals, or we might get phone calls, and all of those are considered technical assistance. But when we send information back out, 9 times out of 10, we are referring whoever asked that question, we're referring them to a specific resource on our website or another website, or setting up information to do a training like we're having today for individuals, or just time to have discussion about workflows or something like that that's individual to each group. We also keep our pulse on the policies that are going on both nationally and within our 4 states. Just yesterday, we sent out this morning, we sent out our monthly newsletter. You can join our newsletter on our website. And we had information on legislation in Illinois and in Indiana in this month's newsletter. In addition to our webinars that we hold within our region, we do have a podcast called A Virtual View. Twice a month, we offer virtual office hours, which are a 30-minute quick interactive discussion around a specific topic. Friday is our last in the series of 4 telehealth workshops that have CMEs for physicians. Registration for that is closing this afternoon at 3 o'clock. And we are working on getting our training and demo center up. We have some extra funds through COVID CARES Act from March of 2020. And we are getting staff trained on that equipment so that we can allow for individuals to make appointments and come into the office to see that. All right, so speaking about COVID, so we're now, 14 months into this. Last March and last April were the periods of time that we had the most technical assistance request, and there was the most change at the federal and the state level in policy that changed reimbursement for telehealth services. So I just want to give you a little bit of history before we jump into what do things look like today, and Nicole will talk specifically about the Ohio Medicaid program today and what reimbursement is available for maternal health providers. So in at the first quarter of 2020, when COVID first hit the United States, the CMS for Medicare purposes added an additional 80 codes that were part of the CPT code list, but hadn't been recognized as reimbursable via telehealth. They also allowed some audio-only codes to be reimbursable under telehealth. And then the other big changes that CMS did, and we'll look very briefly at this from a regulatory perspective, there's 4 conditions of payment for Medicare reimbursement of telehealth services. The first is the geographic location or the rurality of that patient at a clinical site. That has been removed. So the patient can be at home right now during the federal public health emergency, and they don't have to be at a clinical site. They can be in an urban site or at home, urban or rural, that doesn't matter. There were 3 specific disciplines that were expanded under these emergency waivers for CMS and Medicare, and those were for occupational therapists, speech therapists or physical therapists, and speech language pathologists. So all 3 of those disciplines are currently now able to see patients during the public health emergency and get reimbursed for that video conferencing visit with their patients. There were also a lot of other waivers. If you're interested in the history of all of that, shoot me an email. You can also go to the link on this slide and see the CCHP, which is our National Policy Center, the Center for Connected Health Policy. You can see their fact sheet on all of these changes. But there are other changes for supervision for patients inpatients in a hospital, for patients in skilled nursing facilities. And then historically, for many years, CMS in the July timeframe each year puts out their proposed physician fee schedule for the following calendar year. So in July of 2020, it did come out. Early August, CCHP put together a fact sheet on that. When CMS releases information into the Federal Register, it's in 2 columns on the page in very small print. Sometimes it's hard to digest, but what CCHP does is create a pleasing fact sheet with white space and bullets. It makes it a lot easier to digest than reading the Federal Register. So as I mentioned before, at the federal level, we have Medicare reimbursement for telehealth, and it is, or prior to COVID, was based on 4 conditions of payment. And we'll look at those in just a minute. And then for each state Medicaid program, they have the ability to tailor their Medicaid program to the constituents in their state to best meet the needs of those constituents. And I'm so excited that since the spring of 2019, all 50 states and Washington, D.C. here in the United States do reimburse for some form of telehealth or telemedicine or both. All right, so this is a snapshot of what I refer to as the gold standard for telehealth. This is the Medicare Learning Network, or MLN Telehealth Network fact sheet. This happens to be a copy or the cover page from the 2020 version of this fact sheet. I have not yet seen the 2021 version of the fact sheet. Normally it comes out within the first quarter of the year. We're mid-second quarter, but that's pretty normal really when there are administration changes at the White House. It takes a while to get all of those secretaries confirmed into their new roles, and then we start seeing more information come out. This is just a quick snapshot of what the fact sheet looks like, where it lists all the CPT codes and HCPCS codes, and then the descriptions for those different services that can be reimbursed via Medicare telehealth. When this one came out last year, it came out on 3/17 of 2020 and had links in it to, we were really getting into the heat of COVID here in the United States at the national level, and it had already had links to CMS fact sheets and frequently asked questions. So there's that information if you want to go back and study that. So earlier this year, it was March 18th, that Xavier Becerra was confirmed as Secretary of Health and Human Services. And then not even a month later, he did extend that public health emergency to July of 2021. This is important when we start to look at the 2021 physician fee schedule for Medicare and key in on how long those codes will be available for reimbursement. And historically, throughout multiple pandemics in the past in the United States, the standard protocol was for public health emergencies to last 90 days. And indeed, that is what the previous administration, the Trump administration, did from the start. Before the inauguration and the change in administration, one of the last things that the Trump administration did was to extend the public health emergency from the end of January to the end of April. So when the Secretary of Health and Human Services was confirmed, that was one of his top things to do, was to indeed continue that public health emergency another 90 days into July. And the Biden administration has said they have the intent to continue that public health emergency into the end of 2021 with 60 days notice. So we'll have to wait and see what they do in July when the current public health emergency ends. All right, so here are some of the codes. As I said, historically, the proposed fee schedule for CMS comes out in July of each year, and then in December, they finalize that fee schedule for the following calendar year. Normally in December, it comes out at the very end of the month, but we got an early present in 2020. CMS put that final physician fee schedule out on December 1st. So of those 80 codes that CMS had added under the public health emergency back in March of 2020, they took about 60 of them and have added them permanently to the telehealth fact sheet. So here's an example of some of those. See a lot of things around behavioral health, psychotherapy, psychological and neuropsychological testing, custodial care services for established patients, home visits for established patients, cognitive assessments and care planning, visit complexity for E&M services, and prolonged services. Now those other codes that they did not add to the formal permanent list going forward, they have added those to the Medicare Category 3 telehealth list, which is only to be reimbursed through the end of the calendar year during which the PHE or the public health emergency concludes. So that's why it's so important to understand when the public health emergency is going to sunset, because that will key on how long these codes are available. So since we're solidly into 2022 or 2021, we know that these category 3 codes are reimbursable through the end of 2021. We don't know if the public health emergency will be extended into 2022 or not. If it does, then I would imagine that the July proposed physician fee schedule and the December final physician fee schedule for 2022 would indicate that these codes are either going to be added to the permanent list or continued through the end of the public health emergency to the end of 2022. So I hope that makes sense. All right, audio only codes. This was a very sticky wicket back in March and April and May of last year. There are many individuals in their homes that do not have adequate broadband access. There are other individuals that might have broadband access, but they can't afford a smartphone or a tablet or a computer. So there are several programs out there that you can contact us and get more information on. We don't really have time to cover them today, but there's an emergency broadband benefit program that is going live today. And just yesterday, I saw that the FCC is dedicating another $7 billion, that's billion with a B, to the Schools and Library Fund for schools and libraries to be able to get devices for those kiddos that had to do e-learning throughout the public health emergency and didn't have access to those devices. So this new answer to audio only codes, which CMS does not intend to continue for telehealth reimbursement after the end of 2021, is this new HCPCS code G2252. Now this is for a virtual visit between a patient and a provider. That is a discussion. So for whatever reason, they can't conduct an audio video visit, so they do a phone visit. That discussion has to last from 11 to 20 minutes, and it cannot be preceded in the 7 preceding days or followed in the following 7 days by another in-person visit. So it's just a discussion between a patient and a provider to mitigate some circumstances or get a prescription or that type of thing for which there is no need for an in-person visit. So if you are in a situation where you need to do audio only visits, I encourage you to use this code with your Medicare beneficiary patients so that the data is there for CMS to analyze to understand the importance of its utilization and continued use of that particular HCPCS code in these types of situations. All right. And as they always do when there's large legislation that they want to get the word out, CCHP did create a fact sheet for the physician fee schedule, the final physician fee schedule for 2021. And here's the link to that. All right, I'm going to pass things over to Nicole and let her take it away and talk about Ohio Medicaid.
Thank you, Becky. Hi, everyone. I'm Nicole Small. I'm with Ohio Medicaid. Just to provide a brief history of telehealth for Ohio Medicaid, we've had a policy in place since 2014. So that was our first dipping our toes into the water, so to speak, of telehealth. So it was initially called telemedicine. It was limited to a hub and spoke model, a very narrow list of providers. So it was really intended for psychiatric services, evaluation and management. The patient still had to present to an originating site, so they couldn't be at their home or any other location. The patient still had to present to an office. So the intention there was that patients could, in rural areas of the state, could access specialists from other areas of the state. So that was kind of the impetus of our first telemedicine policy. So with that, we also required the patient and the practitioner to also be located more than 5 miles apart. So we wanted to prevent, a big hospital system from calling from the 10th floor to the 5th floor, things like that. So we still wanted patient-centered care. So that's why we had the restriction on, the 5 miles apart. So fast forward to July of 2019, so mere months before the public health emergency, we had adopted an expanded policy. So in this, we added more practitioners, a lot of behavioral health practitioners. We allowed patients to be at their home. So previously they had to present somewhere. So now they could actually be at their home or school, a lot of different locations that they could be physically located in to access a telehealth service. And we removed restrictions on practitioner site location. So we added practitioners, we allowed a lot more flexibility as far as where the patient and the practitioner can be. And then we also added more services to go along with the practitioners that we added. So then in March of 2020, with the public health emergency, we implemented some emergency rules. And so those were done through executive order, so signed by Governor DeWine, and those are only effective for 120 days. So they're time limited rules that are implemented. So, they have a firm expiration date. So we filed several emergency rules just because we were, things were evolving and we were working to make sure that there was no gap in the covered telehealth services. So we do have, there's probably four emergency rules we did. And then we followed it up with our formal rule filing process. So that was the policy that we implemented in November of 2020. So that was what we call a permanent rule, in the sense that it doesn't expire after 120 days. It actually continues until we actually change the rule. So that we were able to put into effect November 15th, and that made sure that there were no gaps in the available services or practitioners that could provide telehealth during the pandemic. So there's a lot of activity on our side last year to get it, to get the policy that we put in place in November. Next slide. I don't know. Oh, I have that. I have the power. So the policy that we expanded in November, that included more providers. So we did add, similar to Medicare, we added audiologists, occupational therapists, a lot of those skilled therapies. And also in Ohio, there are, occupational therapy assistants and the practitioners that work under that supervisor level licensed individual. So we allow, not only the occupational therapist and those sorts of providers, but the assistants that also work with them can provide a telehealth service. So we did add Medicaid school program practitioners, dietitians, which, provide a lot of different services. So those were expanded to allow that. And then also dietitians that provide lactation counseling. So that was another service that was added if it's provided by a dietitian. So we did include, similar to the assistants for the skilled therapies, we added the supervised behavioral health practitioners. So in Ohio, there's a lot of, there's licensed independent social workers, there's licensed social workers that have to be under supervision, but then you also have trainees, assistants, interns that work under these practitioners. So our policy expanded it to include all of these individuals. So it really expanded the pool of practitioners who could actually provide a telehealth service. So it really expands access to, especially behavioral health services and things like that. So we were excited to get that incorporated into our rule. We also incorporated dentists. So there is a teledentistry bill in Ohio where dentists can provide limited oral evaluations through video. There's like a special scope, I guess, that's used. So it's very limited in the services that dentists and optometrists can actually provide. I know initially we were like, I don't know how you do dentistry through telehealth, but the technology is really evolving, and so that would allow for a hygienist to be there with the patient, and then the dentist could be consulting from another location. So that we've seen that as a big development in the telehealth world, so to speak. We also allowed, we know we had a lot of homebound individuals, so we included private duty nurses and home health and hospice agencies. So not every service that they provide could be done through telehealth, but we allowed these practitioners to be eligible to provide telehealth for certain components of the services. So this is just what we've expanded since July, so in response to COVID, but we do have quite a big list of practitioners who are eligible to deliver telehealth services. So this isn't the exhaustive list, this is just what we've added in response to COVID. And I'll talk about some resources that we have that lays things out, makes it a little bit easier to see the full picture. It's hard to put it all in one slide. So with the practitioners that we added, we included more services. We did look a lot to Medicare and what they were doing, and adopted a lot of those procedure codes. So the remote evaluation, virtual check-ins, online digital evaluation and management services, remote patient monitoring, a lot of the skilled therapies. So a lot of things that, you know, correlate with the practitioners that we added. So this, you know, greatly expanded access to telehealth services. You know, in the beginning, there was a stay-at-home order and elective services were prohibited. And so a lot of people were at home and utilization of in-person visits really plummeted. So this allowed for people to still access care and in a meaningful way. So this, again, isn't the exhaustive list, but it gives you a sense of how much it was expanded just in response to COVID. So we do have, you know, back to 2014, we've developed different billing materials for providers. We've worked with different work groups, and so these materials have kind of come out of the interactions we've had with stakeholders of, you know, that it's difficult to bill, it's kind of clunky. Our original policy was very confusing even to us, you know, so we were trying to put it in terms that's easier to understand. So, you know, going back to our policy, beginning in 2014, we have telehealth billing guidelines out there to assist providers. So, you know, depending on the date of service, we have instructions for, you know, with our policy in November that was implemented, there are specific guidelines for those dates of service, and then also prior to that. So these are the links just to get you to where you know, depending on the date of service, which resource you would refer to. And so these are pretty comprehensive documents. They include, you know, instructions for professional claims, which I think this audience would be mostly billing on a professional claim. Gives a lot of good information there. And then specific instructions for FQHCs and RHCs, the rural health centers, so that because they bill a little bit differently for Ohio Medicaid. So there's a lot of good information there. We tried to be reactive to kind of the questions that we get and to help it make it a lot easier for providers to actually implement a telehealth workflow in their practice.
Great, thank you so much, Nicole. And you know, of all of the state Medicaid programs that we work with, you guys do the best job. Let me tell you what, on those fact sheets. They are very comprehensive. Thank you.
Thanks. Yeah, they're helpful for internal, they're helpful to me and internal people. So I'm happy to hear that it's helpful to others as well. Thank you.
Mm-hmm. All right, so just some more things about COVID, just from the federal perspective and again in the state perspective. With the waivers, the first relaxation of the HIPAA rules all the way back in March of 2020, at the federal level and at the state level, there were waivers put into place that allowed providers to use video conferencing with patients at home and to use a platform that was not specifically a HIPAA compliant platform. So all 4 of our states that we cover, including Ohio, are on here with the specific language that is in their Medicaid program for their waiver. Now, Nicole, with the 120 days in the new, I guess, Should clarify that 120 days is 6 months, so it's past 6 months. What is Ohio saying these days now with the new rule on audio only?
We are still deferring to the Office of Civil Rights. They put out that's where we got the information about the public facing. They came out with a notification to providers. So we're still deferring to that. We haven't
Okay.
changed. We're just following what the Office of Civil Rights has put out.
So that is still true, what's on the slide today.
Yep. Mhm.
Great, thank you. And so, every state kind of defined it in their own manner, but basically said the same thing, that you could use something like FaceTime or Facebook Messenger video, or Google Hangouts, as long as it wasn't a public facing platform like Facebook Live. Now that we're 14 months into the pandemic, the rumors that I'm hearing are that once the public health emergency sunsets, those HIPAA rules will come back into full force. So now is definitely the time, if you haven't already in your organizations, to make sure that you have a HIPAA compliant video conferencing platform in place. And if you have questions about that, certainly you can send emails my way. The top 4, and again, we have to be vendor agnostic because we're federally funded, but the top 4 HIPAA compliant video conferencing platforms that we hear of in our region include Doxy.me, Doximity, Microsoft Teams, and Zoom. We were working earlier this week with some genetic counselors, and many of them have Epic as their electronic health record, and they've been using the MyChart or the video module within Epic to do their video conferencing. Now, we always want to have a backup, and maybe your backup is FaceTime or something else that is or is not HIPAA compliant, but then you check with your regulatory folks about how you should bill that based on, you started with a HIPAA compliant audio video platform, and then maybe you had to revert to telephone for technical reasons or something like that. All right, consent forms. We got a lot of questions about consent forms early on in the pandemic. We do have several samples on our website under resources and sample forms and templates. As far as the space, prior to COVID, as Nicole and I have both mentioned, patients had to be in a clinical space. So typically it was a patient room, like you would see at a primary care facility. With the advent of COVID, all of these existing technologies for delivering care virtually are still around, but we're seeing them get smaller here. So these telemedicine carts have been around for 15, 20 years, and their bottom price as far as a range of pricing is probably still in the $15,000 range, but they can go up much more than that. There are portable totes now. Several vendors do offer that with either a tablet or a PC inside of them. And so these are really good for like visiting nurses or hospice situations, even in the ambulance for an EMT or a paramedic to use with the patient as they're en route. Digital stethoscopes. These are the top 3, again, being vendor agnostic. These are the top 3 stethoscopes that we hear about being used a lot today. They all have Bluetooth technology, the Littman, the Echo, and the ThinkLabs. And there are, for some of them, there are apps on smartphones that you can plug in and actually see that heart and lung data on your cell phone. As far as exam cameras, these are 3 different very popular brands. AMD, GEDMed has the horoscope, and the Firefly exam cam. These 2, the AMD and the GEDMed, the backs of them can be twisted off here. So in the AMD picture, you see something, this is like a tongue depressor, or you can, as you can see, it's detached from the exam camera. You can also put other things on it like the otoscope to go in the ears. Here you see the otoscope attached to the GEDMED. And then the Firefly is really just a general exam cam that is good for looking at moles or freckles or wounds on skin. The National Telehealth Resource Center for Technology is what we call TTAC, but it's the Telehealth Technology Assessment Resource Center. And they have a variety of toolkits, videos, comparisons of different types of technology. If you need assistance with making a choice on which type of technology that you want to use. I mentioned EMR integration. I mentioned Epic earlier with their MyChart. Epic was the first EMR or EHR to adopt a patient portal back in 2012. Cerner also has interoperability for video conferencing. They partnered with Amwell in 2016. Allscripts partnered with Video in 2017. Meditech announced virtual visits in 2017, and then Athena Health had implemented video conferencing within their EMR in response to COVID. And this came off of this particular news article. All right, so for the most part today, when there is a telehealth audio-visual conversation or encounter between a patient and provider, the patient's at home. So I mentioned the consent templates that we have available on our website. We do also have documentation on what does consent and documentation look like according to the Ohio code. And we can send that out. We're going to talk a little bit about the patient environment and then vital signs. Some of these things like scales and thermometers, especially, I would probably guess 95 to 99% of all of us here on this call and all individuals across the United States have access to those at home. A blood pressure cuff and a pulse oximeter, maybe not as much, but if you're treating a patient with a high-risk pregnancy, certainly that might be something you would recommend that they have at home to continuously check their blood pressure every day. So when it comes to establishing those patient-provider relationships, Ohio is one of the states that made changes to this for how to establish that relationship virtually, and also allowing prescriptions for controlled substances to be provided. I don't imagine that you would do this very often with a prenatal or a postnatal female, but just so you're aware, right now during the public health emergency, you can meet the patient on video conferencing and establish that patient visit according to the laws in your state. And you can also prescribe based on the waivers that the Drug Enforcement Agency or the DEA has in place, prescribe a controlled substance on that first telehealth visit. Yeah, I have Indiana on that slide, but it's true for Ohio as well. I want to talk about what I call webside etiquette. Instead of bedside etiquette, website etiquette, because it's becoming so much more common for providers and patients to meet over a video conferencing platform. Oftentimes it's not, you as a provider have been so busy you haven't really thought about it. Maybe the patient's never had a telehealth visit before. But these are some tips and tricks for you, things to think about. Here in my office where I'm at today, I've got my blinds closed so that you're not getting a lot of glare. Actually, I neglected to put on my video light. Alexa, video lights on. So this reduces the shading on this side of my face. So I've got my two monitors here on my desk, and it's a standing desk, and then a hutch behind them. And I have a craft light up here in the corner on top of the hutch, and it's a gooseneck. So I've taken that light and I've turned it up so it's bouncing back off of the white ceiling and providing a lot of natural daylight into my office. I've got a clean background. I've got it, let me go ahead and show you. I've got it blurred today. I like that video setting in Zoom, and Teams has it as well. But I could have my normal background up because I've taken time to make a pretty background and put my logo. I got that from Shutterfly. Just asked them to print my logo on canvas and on a certain specific size, so it's on balsa wood. I could have, any kind of background that I wanted, but sometimes on the virtual background there's pixelization, and I don't always like that. So I usually either do the blur or the normal background. Now I could invest in a green screen. And if you go to your favorite internet search platform and type in green screen, you will find all types of things, from big, huge 10 by 10 screens that you can hang up, or even green screens that sit on the back of your chair. So if you use a green screen behind you, then with the addition of the virtual background, you don't get that pixelization. But other tips that are actually written on the slide is, wearing professional clothing as if you were seeing that patient in person. Maybe wearing a coat with your logo on it or your name. Obviously, depending on the platform you use, I could rename myself here and put an organization on this, so that it's very clear who I am and what organization I'm representing. And same thing for the patient. When we're on these video calls, we see about this much of each other. We don't see what's out in the rest of the room around us and our surroundings. And especially for the patient, it's really important to ask them to identify themselves and if there's anyone else in the room with them, because you certainly want to include family members in the conversation if they're there. If there's loud children in the background, maybe you want to say, hey, let's reschedule, or ask the patient if they can go to a more private area. On the same page as that, if you have a resident or a student, fellow, whatever, with you as the provider, you also need to make that information known to the patient, just as if you were in person. All right. So I started off today being very transparent that I have two screens and I've tried really hard. I moved my thumbnail of myself right underneath the webcam on my screen so that it looks as if when I'm watching myself view, like right now, or if I tilt my eyes up just a little bit to look at the webcam, there shouldn't be any change really in what you see when you look at my face. Something else that I've done is I've invested in glasses that, because of my age, I have bifocals. So I have reading view bifocals, but then the prescription in these glasses is set for the computer, for the distance between the computer. Prior to that investment, I was using these readers. And while I can see what I need to see, when I'm giving a webinar or presentation virtually, there's a lot of glare on these. And so it's difficult for you to have eye contact with me because of the glare on the glasses. So this investment helps me to connect with you more. So the camera positioning is very important, and really it's like getting your photo taken for a large group photo. You need to keep your eye contact there with the camera. And it takes getting used to. It's not necessarily normal or easy or anything like that, but when you're presenting as a provider to a patient, that's how you're going to get the best connection with the patient. All right, so I've done some research about physical exams and necessary items. So this one comes from one of my sister TRCs, and they took that from American Telemedicine Association's Live on Demand Primary Urgent Care Guidelines. So these are here for you to think. If you've never had a virtual visit with a patient, you may think, but I can't touch the patient. How efficient can I be? And there are actually a lot of things that you can do with a patient, even if you can't touch them. So, a lot of this is taking of history, signs and symptoms, those types of things. So in the clinical setting, the patients, you may have a medical assistant that comes in and takes the patient's blood pressure and weight and all of that. But at home, again, most homes are going to have a scale and a thermometer, and they might possibly have a pulse oximeter or a blood pressure cuff. So you can still get most of those basic vitals. Again, some examples of equipment. You're probably not going to send a kit like this home with every patient because they're probably in the $1,500 to $3,000 range. Even some of these other ones are a little bit more expensive than what you want to send home with your patient. But if your patient has the ability to go out and buy a blood pressure cuff, these are just off of Amazon. These blood pressure cuffs run from $26 to $71. And pulse oximeters are in about the same price range. So these slides and this particular figure comes from the U.S. National Library of Medicine, National Institute of Health, Public Health Emergency Collection. And so they talk about how to collect different vital signs. If you're a patient and you're going to take your blood pressure, they want you to sit for 5 minutes. Other things that you can do if you need to do some type of a neurological exam or something like that, by listening to the patient's speech or watch them walk around the room. For the extremities, you could certainly have the patient hold up their hand or their leg to the camera and show you what that looks like. Certainly you could ask them to do deep breaths and hear, just not with a stethoscope probably, but just listen to them and pay attention to them. If you need any labs or x-rays, it is better for the patient's local economy if they are in a suburban area or a rural area, that those ancillary costs of labs get to stay local in that economy. When you talk about the economics of telehealth, especially in rural areas, it's usually either the schools or the healthcare facility, if it's a hospital or a clinic, that has the most impact on the local economy as far as the number of employees that they employ and the revenues that come through their organizations. Here are some additional references. I love these Old Dominion University training videos, and they have some examples specifically of abdominal pain, ear, nose, and throat, and there's a couple others where in the video you see the provider talking over video conferencing with the patient and walking the patient through doing a self-exam to gain the information that they need for the outcome that they want to get. So there's all kinds of things that you can do with your patients when they're not physically in the same room with you. And then lastly, what is the future of telehealth? I get that question a lot. Either that or when's the public health emergency going to end? And two quotes that I want to share with you. So last June, Seema Verma, former head of CMS, said that the genie is out of the bottle. So it's difficult to put the genie back in the bottle. And then this February, just a couple of months ago, I was at a virtual National Rural Health Association Policy Institute, and their head VP of Government Affairs, Carrie Cochran-McLean, said, the toothpaste is out of the tube. Now, I don't know about you, but I've had toddlers in my life, and thankfully they're old enough not to do this anymore, but when they take the middle of that toothpaste tube and they spray it everywhere, you're never going to get that toothpaste back in the tube. And I really, I think telehealth is here to stay. I think it's going to change the way patients and providers interact. and the way that healthcare is delivered in the United States. There are multiple ways that you can connect with us here at the UMTRC if you have further questions past today. We have our website, umtrc.org. We have our podcast, A Virtual View. We have a YouTube page, a Facebook page, a LinkedIn page, and we also have a Twitter account. I forgot to get that on here. That's fairly new in the last month or so. And you can also sign up for our newsletter that comes out generally the beginning of every month. Here is the contact information via email for all of us that are staffing this webinar today. And now it's time for questions. As you guys are thinking of questions that you want to ask, Carolyn, do you have the survey ready to go? I forgot to ask you before.
Yep, let me get it posted.
All right, so in your chat, you should be seeing a link to a very quick survey. I got a question about the slides being sent out. As soon as I get them turned into a PDF format, give Caroline a couple of days and you should see them in your inbox. Other questions? Wow, Nicole and I must have explained everything crystal clear. This is a good question. When you say the genie is out of the bottle, do you foresee that health plan payers will recognize this? Nicole, do you want to talk about the parity law in the state of Ohio?
Sure. I'm not, I didn't work like super close on the parity law, but there is a parity law that requires the same coverage for mental health services as there is for physical health services. So that's always kind of on our radar when we're making policy is, is this going to conflict with parity? So I think, every payer is going to do it a little bit differently, but I think with the states that have the parity law, it's a little bit more of a, I guess, something you can't get around, like it's something you can't really get around, that it's really going to have to, you're going to have to look at these things in the sense of parity, and you can't just do whatever you want. So I think with CMS making changes for how Medicare is reimbursed, a lot of state Medicaid agencies, including Ohio, do look at what Medicare is doing. So I think them expanding, the list of covered services permanently for some of them, I think that's very helpful to kind of lead the way for other payers.
Mm-hmm. I would agree. And it's kind of interesting and I happen to be a policy geek, but Medicare started paying for telehealth in the late 1990s, and everybody else kind of followed suit. Like you said, Nicole, that the state Medicaid programs would look to Medicare, and then it would trickle down to private payers or commercial payers. And when telehealth really got to be a little bit more mainstream, maybe 3 to 5 years ago, and companies like Amwell, that was American Well to begin with before they changed their name to Amwell, companies like that were like third-party entities where you could go and pay a fee and join up and get on an app. You wouldn't see your own doctor. And so that was very jarring. It's not part of your normal electronic health record. So if I'm going to see someone via telehealth, I'd much rather see my own provider. So I think that through the pandemic, and there were some waivers early on, I'm not positive that they're still in existence, but I think they still are, that mandate that commercial providers cover visits via telehealth, especially, in the early part when we were all staying home. I think that those will continue. My personal opinion is that payers will not have a leg to stand on. There will be such overwhelming pressure from Congress at the federal level, from state legislatures, from patients, that they will have to fall in line. And there are there's some studies, I mentioned the CCHP website. There are many states that have what we call parity laws that say that those commercial providers must, or shall is usually the word that's in those, cover the same services if they're delivered in person or via telehealth. Good question. Any additional questions? All right, well, thank you for joining us today, and I'll give you all 5 minutes back in your day. Have a great day.
Thank you.
Thanks.